Good afternoon, everyone. Thank you for coming. My name is Celeste Arrington. I'm the director of the GW Institute for Korean Studies. Thank you very much. I see a number of familiar faces, and it's very nice to welcome you for today's topic. I'm especially pleased to showcase the brand new research that's cutting edge by Jung's own postdoctoral fellow for this year. Unfortunately, due to budget cuts from the Korean funders, we will not have a postdoc for next year. So this is kind of bittersweet, but I really have admired Chongun's research that I've learned about over the years, over the course of the year, and she's also played a very important role in leading our undergraduate research fellows program, and so it's my great pleasure to hear more about her research today. In order to moderate this discussion, I am grateful for my colleague and Jung's core faculty member, Richard Grinker. He's a professor in the anthropology department and has a extensive bio that you can read more about in the program. But for now, I'll just turn it over to Richard. So thank you for moderating that.
Thank you. I'm delighted to introduce Kwon for her talk entitled "What Went Wrong? Problematizing Suicide Prevention in South Korea." Kwon is the postdoctoral fellow at the GW Institute for Korean Studies. She is a cultural and medical anthropologist whose research examines the intersection of mental health, gender, local health systems, and governance in South Korea. Her current book project examines how young Korean women experience and conceptualize suicide and how they reimagine care in response to state-led prevention initiatives. She received her PhD in anthropology with an Asian Studies certificate from the University of Pittsburgh. Her research is timely and it is important. Since 2003, South Korea has consistently recorded among the highest suicide rates among OECD countries. And Kwon is beginning to publish in very prestigious journals on the subject. Her article that came out maybe a month or two ago in one of the most prestigious journals in anthropology, culture, medicine, and psychiatry, makes an important intervention in suicide scholarship. Suicide scholarship has been hampered by a focus on data points and variable-based explanations, and her focus, as you will see, is ethnographic, it's nonlinear, it's cumulative, and ethnographically rich. It's an ethnographically rich framework that will be immediately useful across academic, policy, and clinical conversations because it takes seriously not just data points, but how people make meaning of suffering. As she wrote in this article in Culture, Medicine, and Psychiatry, quote, rather than isolating discrete events or static risk factors, it emphasizes the long-term cumulative and relational processes through which suicidality develops in connection to both interpersonal relationships and broader societal forces. And I strongly recommend people read that article in Culture, Medicine, and Psychiatry, which is easy to access from Google Scholar. At any rate, enough of me. I welcome you and thank you all for coming, both in person and online. And please give a warm welcome to Dr. Kwon.
Good afternoon, everyone. Thank you very much for Professor Arrington for welcoming remarks. Thank you very much, Professor Brinker, for moderating this talk and introduction and highlighting my intervention in the scholarship. Thank you so much. I would like to also thank Jung's GW Institute for Korean Studies for making this opportunity for me to share my work. And I would like to thank Jung's core faculty and our wonderful staff team, Hamin and Ravina and Lily May, for making this talk happen in a seamless way. I would like to start with this photo, opening with this photo. I think this photo is very representative example of the state suicide prevention project. There are multiple vectors over here. I will be introducing some of the vectors in this photo. let's take a closer look at this photo and the slogan and the screen door in the background. Take a closer look over here. So when we take a look at the main one, 사람을 더하세요, add people. It follows with, this is my translation, add your voice, add your touch, add your heart, add you to those who need help. So that's the slogan, and this is still the main slogan of the State Suicide Prevention Project. And I brought this slogan because of the multiple factors. First, it highlights people. Here, people means like connection. So it highlights some isolated society, and people are like, there are like lack of a connection between people. It highlights like voice, touch, and heart to emphasize the necessity of emotional and psychological aspect of suicide prevention. Lastly, there's add you, add people, and in this case, you are mostly like family members and friends, like all citizens. And this is to highlight the responsibility of individuals and family members and friends to prevent suicide. Also, this is a screen door, and some of you may be familiar with all the screen doors in the subway station, metro station in South Korea. Installed to prevent suicide early 2000, to prevent people to jump down the platform. So that's the main, like in the earlier stage of suicide prevention, that was the restricting mean parts of the suicide prevention in the state, from the state. Also, there's a famous actor, Yo Jung-gu. He's the actor in South Korea, bringing celebrity or star in the main part to increase the awareness of the severity and necessity of suicide prevention. So, like, this is just a one photo, but there are multiple factors involved in to like kind of represent as a represents example of suicide prevention in South Korea. So for this talk, I will be starting with some brief introduction of my broader research, not only this talk, and I will briefly mention my method and some of the background information necessary to understand some of the state suicide prevention projects. The body parts of my talk is I will use the threading keyword is as narrowing, and I will show there are 3 narrowing aspects: suicide, the concept of suicide, the concept of care, and concept of gender. In gender part, it will be mostly like overlooking or making an invisible gender aspect. So that's the body part of my talk. And as the concluding marks, I will be discussing a little bit about why suicide prevention is happening in this way. There are some contributing factors, and I would like to end with some of the budding thoughts of my own, like if there are any like a better way to prevent suicide, and some of the dilemmas include in terms of suicide. So as I said, this talk is part of my book project. I have broader book project, and my book project is titled Reclaiming Suicide and Care: Young Women Suicide and the State Suicide Prevention in South Korea. As you can assume from this title, there are 2 main pillars in my project. And one pillar is I call Young Women pillar, and the other one is I call like a state pillar. And for these 2 different sessions, I ask 2 questions to each pillar. How do young women in their 20s and 30s experience and frame or understand the concept of suicide through their experience? I usually look at their experiences of suicidal thoughts and suicidal attempts. So that the article from that aspect is the one that Professor Brinker introduced, Living in a World Without Respect. That's the part of the young women part, it's suicide part. And then I asked what kinds of care they think they need in order to reduce their suicidal thoughts or attempts. And they were not using a lot of state services, even though they know there are some services they were willing to not to use it very actively. So they are actually broadening the scope of institutional care, broadening outside of side discipline and the state public health system to create some of the innovative systems, like some of them were just creating some alternative families and engaging in activism, and they were viewing that as a kind of care they need or they want, or making them feel better. So another part is the state part. That's the part that I will be focusing more on this talk, mostly on this talk. And I will be talking about how does the state conceptualize suicide. And I also ask what kinds of care are provided in the state suicide prevention project. And ultimately, the reason why I brought these two pillars are that they have different ideas and different practices. So I am trying to show that there are some misalignments and divergences between their understanding of suicide and practice of care. That's my broader book project. Briefly about my methods. So I did my ethnographic fieldwork as an anthropologist for 15 months in South Korea, mostly Seoul metropolitan area. And that was during 2021 to 2022. And I would like to do some follow-up research this summer as well. For the young women part, I mostly drew on the interviews because I wanted to listen to more of their life stories in a very long temporality. But I did some participant observation. Well, you might think that how could you do participant observation in the study of suicide? This is not so. I did participant observation by participating in some of their everyday life. Like if they were trying to go to some of the events for the public events or like book talk, or they were engaging in some activism, I followed there together, not related to suicidal acts. And some of them invited me to their place, and it was good understanding of how they're living in their everyday life. And I also invited some of my interview participants to my place to as anthropologists we say doing hangouts, but it's actually looking at how people are actually acting in everyday life. For the state part, that's where I did a lot of participant observation. So I did participant observation in suicide prevention centers, and I will be talking a little bit more in the system of suicide prevention, the later slides. I was mostly volunteering in the centers, and there were many activities that I was involved in. Some were answering hotlines. People who were calling for hotlines, I answered them. I got training first, and then I answered hotlines. There were some activities not receiving phone calls, but calling to clients regularly. So I also made some weekly phone calls by going to the center and checking in how they're doing. And I will be talking, introducing some of the episodes that I had in that part. I also conducted interviews with so-called professionals, including current and previous employees of suicide prevention centers. And in addition to that, I also interviewed psychiatrists and psychologists who are working in the private sector. So I am mostly looking at the state part, but looking at the private sector as a complementary method. As you will see in my talk today, I looked closely to policies and government documents. Today's talk involves a lot of policy images. So some of the background information, as Professor Brinker also introduced, so you may be all familiar with the high rates and the top ranking of suicide in South Korea. South Korea's suicide rate has been peaked from 2003, and since then, Korea was taking the top rank, having the top rank among OECD countries, member countries. I just brought some numbers in for comparison. South Korea's rate is 27.3. That's death per 100,000. So that's a number, how the numbers are calculated. Japan had some higher suicide rates, but they had their suicide prevention efforts were really successful, so that their rates got really decreased a lot. Now it's almost like lower, much lower than South Korea. US has high numbers, but still lower than Japan and South Korea. That's the ranking and rates of suicide. So when the state's suicide prevention happened, this state project started from 2004, and I will show you that this year is not a coincidence. Since 2004, there were various general plans every 5 years. It may be a little different, but it's pretty simple. There are 5 basic general plans for suicide, and this one, like 2011, this is the one when the act was established. What act was created? So 5 general plans. In 2011, the act was created, the Suicide Prevention Act, and it is definitely expanding state project. So when I said to look at the year 2004, there are multiple factors involved in the beginning of this suicide prevention project. First of all, the rate got increased after having IMF crisis in South Korea. So that's when really the suicide became a severe issue, and everyone became aware of the high rates of suicide. So the number wise, that's when the rates peaked. But there are other factors as well. If we look at the public health history in South Korea, 1989 was when the national health insurance was covered to everyone. So like the public health system was getting stronger in the early 1990s and early 2000s. So that's like 1990s and 2000s were when public health policies and infrastructures are getting established in South Korea. In addition to that, WHO, World Health Organization, announced in 1996 that suicide is a public health problem. So previously in South Korea, suicide was more understood as some of the protests, attached to some protests, a lot of labor movements. In case of Cheontae, it was looked more viewed as some resistance to society. That was pretty widespread before 1990s and before this state project. But also influenced by WHO pronouncing it as a public health project. That's when the suicide also became the most important public health issue. Also, in addition to that, the 2003-2004 was when South Korean population is starting to decrease. So when we think of the aging society, Committee on Aging Society on some basic plans for low fertility rates, this is the same period when this aging society and fertility rates plan is starting to create it in South Korea. So there are a lot of factors being involved in the start of this suicide prevention project. I would like to introduce briefly about the suicide prevention delivery system because it's very wide and hierarchical and widely spreaded system in South Korea. So the yellow one is the Ministry of Health and Welfare, and suicide prevention project is being hosted and operated by and planned by Ministry of Health and Welfare. And there is a control tower called Korea Foundation for Suicide Prevention. It's like following the policy made from Ministry of Health and Welfare, the Korea Foundation of Suicide Prevention is doing all the work and managing all the different suicide prevention centers in local places. And I brought this over here. There are some city and provincial suicide prevention centers, and the number over here is the number of the centers. And in total, like for larger government, like city government, there are 13, and there are, when we go deeper into like municipal government, there are 42 suicide prevention centers all across the country. I put some numbers in parentheses over here because there are separate like mental health welfare centers, 정신건강복지센터, and some of the suicide prevention team is included in the mental health center, and some are separate. So like they're still in the very same direction and orientation, doing the suicide prevention and mental health work in broader public health system. This one, the crisis response center, is a notable thing. This is actually emergency hospital ERs. They are designating hospital ERs to make connection with the public health system, and they are referring some of the at-risk individuals to the centers. So even though I call this as a public health system, there are some private and public connection in between, and I will say in the later slide, I am thinking about the term like medical state complex in these connections, and they are like closing and tightening this connection between public and private. There are some NGOs in this public health system as well. There were some existing faith-based NGOs who are doing hotlines, and they were working on suicide prevention work. Now they are being supported by the government. That has some pros and cons because they have to align their orientation with the state's project. So even though they are non-governmental actors, they are still aligning their messages and directions to the state part. So this is the system, and I mostly did my field work here in the like the municipal suicide prevention center and some of the NGOs. That's where I did my participant observation. Some of the main activities they do for the suicide prevention, there are 3 pillars as they introduced: prevention, intervention, postvention. And as you can see the number over here, they put most effort in prevention part. What they're doing for prevention is regulating some media words, especially like blocking the words suicide. And some of the campaigns, like the screen door slogan, that's the thing that doing for prevention. After the establishment of ACT, every school and military and some other places workplaces as well, suicide prevention education became mandatory. So that's the effect of the creation of the Act. So this is also a part of prevention project. There are some other things like managing means, like for the rural area, restricting pesticide was a big thing because a lot of farmers and rural elderly people in rural communities, people were drinking pesticides. So like that was the early project to making a box to lock the pesticides, whole place. Yeah. Nowadays, they're increasing some of the process called psychological autopsy. It is getting bigger and bigger. What the psychological autopsy is inspired by the physical autopsy. It's not dissecting the human body, but it is trying to identify the exact cause of suicide by gathering all the family members' conversations, gathering all the legal and medical documents. So like kind of making some comprehensive understanding of a person who is passing away and trying to identify that cause of the suicide. And that's usually reinforcing the policy direction on how they can prevent suicide better. So I was talking about this later, but like there's a tendency called like evidence-based medicine or evidence-based policy, and psychological autopsy is part of increasing their like evidence-basedness of suicide prevention. There are some supports to family members. There are some for recruiting families, helping legally and some administrative thing after person passes away. But these are some most bigger pillars of suicide prevention. Moving on to the main part, what I would like to problematize with the suicide prevention. I use the threading keyword of narrowing to show 3 different threads. And the first one, suicide, 2, care and intervention, and 3 is gender. So let's start with the understanding of suicide. This image may seem very a lot of things are going on over here. This is the main image, but those are the translation of mine. The simple way to understand is that they are, and by the way, this is from the first 5-year general plan, starting from 2005, saying that they admit that there are some biopsychological factors in suicide. They do admit that there are some socioeconomic factors in suicide, but these factors will come through the clinical depression. 80% will show the clinical depression. So their logic is it'll be very effective or efficient to intervene clinical depression to prevent suicide. And the following rationale or logic is coming. And as you can see, the close link between depression and suicide is being made. So this synthesis is right after the model that I just showed. It says, quote, "It is known that 80% of biopsychological and socioeconomic factors lead to suicide through depression, and the remaining 20% commit suicide in an impulsive state." So rather than focusing on biopsychological or socioeconomic factors that are difficult to change with modern medicine or economic conditions, it is more effective in preventing suicide to focus on depression, which is at the crossroads of suicide and can be treated through early detection. So that really encapsulates, condenses the idea of making closer link between depression and suicide. You might wonder if this is just the story of 2005 and the tendency is changing. And I show that it's not. It is continuing tendency. And this is the most recent general plan from 2023. And this is the translation of this part. It says the number 1 motive for suicide in Korea is mental problems. And recovery is possible with appropriate treatment, such as counseling and medication. So putting psychological counseling, and psychiatric treatment in the main actor and field of intervention. Then, so I talked about how suicide prevention project medicalize and make it as a psychological issue in understanding suicide. And we can ask what are some side effects of medicalizing suicide. And I view that there are several side effects by medicalizing suicide. First, state is constantly emphasizing suicide as individual mental health problem. And in this case, I think suicide can be pathologized. Suicide can become to be seen as a medical issue, and people are sick, so they have to be treated. And suicidal individual becomes a patient. It also has some effect of sidelining broader socio-political and economic factors. It has some, and by highlighting the individual aspect of medicalizing suicide, it has the effect of absolving the state and absolving the society's structural intervention. And it also strengthens the medical state complex. I used this term earlier. It is strengthening the medical state complex where private and public connection become closer. I don't think it has like side effects, but it has some tendency of making symbiotic relationship between state and private sector and expanding the private sector of disciplines like psychology and psychiatry. So many scholars actually talked about the medicalization of suicide in anthropology and sociology, and some scholars in Korean studies as well. What I would like to add are the following aspects. And the first one I add is the idea of social is also reduced. In the state project, what they mean by social is very limited. First, they only highlight the lack of social connection, the lack of isolation and loneliness. So that's why they're saying like add people in your life. That's the way to prevent suicide. So I think regardless of other structural factors like housing crisis or anything like job crisis or anything else, they are focusing on the isolation and social connection and attributing this to individuals or citizens' duty to make connections. Another trend is that there are some movement or interpretation of high suicide rate by saying, oh, South Korea has low depression treatment rates because of stigma on psychiatry. And I'm not saying that that's not true. It is true. But by saying that it's because of low treatment rates, it's also strengthening the link to depression and suicide again, and also reducing it as a medical treatment problem again. Third, when they say social, they highlight that there is a lack of awareness regarding respect for life. So it's saying that nowadays people are not valuing the value of life. And it is reflected in the name of the act and the name of the control tower. I brought the name and it's so long, I cannot even remember sometimes. But this is in Korean, but the English version is this: Act for the Prevention of Suicide and the Creation of Culture of Respect for Life. So it's also highlighting that there is no culture of respecting life. So we should increase the awareness of value of life, and it's also reflected in the name of the control tower. It doesn't reflect in the English name, but in Korean it says Korea Life Respect Hope Foundation. So that's the name of the control tower. In addition to narrowing the understanding of suicide, I argue that there are some narrowing of care provision as well. And this is due to the narrowing of the concept of suicide. So they're connected. And I call this partial care because there are some care aspect of it, but it's not full or comprehensive. When I say partial care, I mean this care only addresses one fragment of the problem. And what I mean by one fragment is that the state separates emotional support and practical support, if I can make some dichotomy over here, and only providing emotional support and keeping the practical, just leave them that. And I view this partial care as partially performative and perfunctory and pretends caring about individuals' life situations. And it actually has the effects of disregarding basic needs of people. This is a photo that I took, and this was when I was receiving some phone calls from the hotlines. And I would like to introduce one ethnographic data vignette when I did the volunteering work, what I call talk check. That's the pseudonym. And the person name is also a pseudonym. I call it Mr. Lee. And talk check was one of the program in Suicide Prevention Center that I volunteered. and I had to go to the center every week and make a phone call to some of the clients. So I had 20 clients. They usually make volunteers to call for some like middle and low risk suicide clients. So I was calling Mr. Lee regularly, and I brought some of my writings that I want to read. So yeah, here it goes. I titled this story, "Just Give Me a Job or Money." That's the title of the story that I call. So Mr. Lee was a top check client in his 60s, and he was very reserved and difficult to engage during our phone calls. He often responded with brief answers like, "Oh, I'm doing fine," or "Every day is just the same." So his short response made it hard to continue conversations and left me feeling nervous. One day in August 2022, he finally shared that he had been applying for jobs but couldn't find one. And I felt partially relieved that he is starting to open in his conversation. In fact, that relief didn't last long. He soon asked if I could introduce him to a job at the Suicide Prevention Center. When I explained that I was only a volunteer and had no power to introduce any jobs in the Suicide Prevention Center, he hung up in disappointment. The following week, he again asked if I had a job for him. When I said no, he suddenly vented his anger, saying, "Then why do you keep calling me just to ask if I had lunch or how I feel? Just give me a job or money instead. What's the use of this phone call?" Although I felt verbally attacked and confused, I somehow understood his frustration. Mr. Lee was financially unstable, and he was too young or not poor enough to receive a pension. But due to his age and chronic illness, work opportunities were limited. While the way he expressed his anger was problematic, I thought his underlying complaints were reasonable. So that's the story of Mr. Lee, and I would like to show through this story that the emotional care being provided in the center is very partial. Meanwhile, there are some practical support provided by the suicide prevention centers. For example, there are some medical treatment costs for attempters when a person attempted a suicide and when they choose to be enrolled in the center, they can get some reimbursement of the treatment they got in the ER and psychiatric clinics. There are some financial support for psychiatric visits and medication, but there are some maximum time, like 3 months or maximum, and you have to prove that you have lower income. As I mentioned, there are some legal and administrative assistance for bereaved family members. They are helping you to do some administrative thing after a family member has passed away. There is some, I'm not sure if it's just a practical support, but there are some ways restricting means, and this might be, maybe it might be familiar to some of you. This is the bridge at the Han River, Hangang, and this part is changed due to suicide prevention projects. How it's changed is that you cannot climb to jump down the river. And another thing is that the bar handle gets rolled when someone is trying to attempt suicide. So there are some of the restricting means and some of the things that they are doing to change something immediately. But otherwise, there are no supports on meals or like housing support or anything related to job and work related, nothing related to harassment or violence. So it's pretty much focused on emotional, psychological, psychiatric support that they're doing. Suicide prevention project. I brought, this is just a quick thing that I wanted to mention. Who cares in this suicide prevention project? Who are the workers and who are being seen as responsible in this project? Well, the employees are mostly mostly social workers. The head is usually usually a psychiatrist. This is another big story, but they usually consign these suicide prevention centers to hospitals. So usually even though it's a public health center, the operating group is hospital. So the doctor of that hospital becomes a head of the suicide prevention center. So there's another like public-private collaboration in this part. So social workers, mental health nurse, they are employed through this job recruitment system, but they are contracted under the hospital. So that's the system. So they call themselves as para-public officials because they're not official like public officials with the regular exam, but they are doing some public work through private contract. So that's how it works. In addition to these employees, definitely there are some lack of workforce. They need more people to work. So some of the centers are very open to volunteers. And I figured through my participant observation, there are two big groups of volunteers. One, college students who want to build their resume, who want to do some public work, to be police or public officials. Another big group is middle-aged elderly women who had stopped their career after having children, but they want to try out something related to social work and many of them were Christians actually. So the connection were there, like career development and doing some religious work together. Other than that, also as I saw the slogan of Ed, a lot of duties or responsibilities are being given to family members and friends. So it's really interesting when we think that this is a state program, but actually highlighting individuals' responsibilities in this project, and what kind of implications that have when we highlight individuals' efforts in the state project. That's really kind of absurd dilemma over here. The last part is the narrowing gender or degendering. I'm not sure the narrowing word here is appropriate over here, but what I wanted to highlight is that they are also trying to minimize the gender aspects and naturalize women's suicide. So this is my favorite infographic in cynical way that I show this photo every time when I do the talk. This is showing the motivations of suicide in 2023. So because it's infographic, they made some kind of simplification of the motivation. But the interesting thing is that these are men motivation. There are some three categories: mental difficulties, economic difficulties, physical difficulties. But for women, there's only mental difficulty. So 56% of people who have committed suicide is because of mental difficulty. And when I was showing this in my classroom, some of the students were noticing that even though they have same categories of mental difficulties for the very left and the right side, for women, the tear is coming out. I'm not sure you can see it very closely here. The tear is coming out. So it's like more likely to highlight the internal psychological thing. But for men over here, there's a cloud overhead. So it's kind of like external forces making you depressed. And that's even though they use the same category, the image description is different. So there are some rationales, and I would like to say that there has been some tendency to pay less attention on young women's suicide or women's suicide because the mortality rate itself was lower. So that was the state's rationale to pay less attention to women's suicide. But it's really irony because they highlight the closer link between depression and suicide. And when we look at the depression rate in South Korea, women have more than 2 times higher depression prevalence in South Korean society. So even though there are some closer depression and suicide link, and even though women have almost a double of suicide attempt rates, not the mortality rates, less attention was given to young women or women's suicide. And usually what happens is that because in relation to the higher prevalence rate of depression rate, it's usually considered as, oh, it's pretty universal and pretty common that women have higher depression rate in globally. And so it's pretty usual or pretty common that we see higher depression rate and lower suicide rates. So that's kind of rationale that that is given in relation to the targeting part. I brought some quotes from one of the previous employee who was social worker in suicide prevention center, and I call her, and she has been working on in the center for 9 years. Now she's working at a hospital, and she is trying to show that mental health in the field of mental health and mental health, gendered aspect is considered as subjective interpretation, and they would like to keep distance from some of the gender organizations and mental health organizations or suicide prevention centers. So this is reflected in her quote when she says, quotes, "When doing mental health counseling or suicide prevention counseling, we were trained that the counselor's personal subjective experience or feeling should not be involved. And gender aspect is considered as subjective experience. Since the field of sexual and domestic violence and suicide prevention is separated, and that I felt the limitation, I took that class training for sexual domestic violence counseling offered by women's organizations. And after taking that, I thought, oh, we have to do some counseling like this. We have to take a feminist approach, and we have to understand and counsel about some certain characteristics of gender. I think those perspectives should be included in this psychiatric setting and mental health setting, but the boundary is too clear." So that this is when she realized some of the boundary making in two different fields. There was this program called Sisters Keepers when the COVID was emerging, and there were some discourses highlighting the service sector workers' suicide. That's when the Seoul Suicide Prevention Center were trying to create the program called Sisters Keepers to better support women in 20s. And because of the backlash, there were some this was not feminist, even not a feminist project, but because of the anti-feminist atmosphere widespread in South Korea, this program couldn't even start and had to be stopped and closed due to some backlash saying that men are dying more. Why do we have to open a program of sister keepers rather than brothers keepers? So there was some program in this time. So keep trying to make some distance between some gender aspects in the mental health field. Okay, I'm going to conclude with some of the contributing factors because I criticize a lot, but I do understand and I do know that there are some factors that they have to do this project in this way. There are many factors involved in. First of all, the Ministry of Health and Welfare is in charge of this project. So nowadays it's the field of public health, so they have to medicalize and psychologize suicide in the limited understanding. And main actors of suicide prevention program are psychiatrists. They are making policy. When politicians make policy, psychiatrists do some counseling because they think it's very professional field. So mostly, like most important actors in this project is psychiatrists. And as I have shown you the hierarchy structure, organizational structure, I met some employees that they don't agree with this project completely, but there is not many discretions for employees to make some changes in this project. Also, there are some metrics driven auditing because this is public project. They have every year, every center has to report how many clients they had, how many campaigns they had, like all the numbers they have to report. And whenever they do something, documentation is always necessary. I met one employee that even though he wanted to buy some meals to the clients, he couldn't because that's not the policy-based activity, and he has to do tons of paperwork for that. Using the term the performative governance that you introduced, the state has to show the performance that they're doing some of the activities because this is a state project. And also, the suicide prevention project is population-based, and because this is focusing on the saving lives itself, regardless of any reason, you have to be alive. That's the population-based intervention has some kind of directing orientation in this project. Last concluding thoughts. So I have been thinking, what would be some better ways? And this is just my budding thoughts on better ways. This is just, I'm just starting to think about as a discussion topic for me. And I was keep questioning, starting from my fieldwork, should suicide prevention exist as a distinct and separate area on its own? I do understand that there should be some mental support for mental disability people, mentally disabled people. But I am questioning if suicide prevention needs a separate project, and why don't we provide more support on direct and need-based practical support rather than doing some supporting emotionally. I'm not saying that emotional support is not important. I do think that it's important, and there are people who find it very helpful, but I don't think that's all that people need. Secondly, I think that it is necessary to talk. There needs to be some space to talk about death more calmly and openly. Currently, the Suicide Prevention Project is simply saying that life is precious, so you have to be alive. But there is no discussion on death and no discussion on suicide. And actually, some psychiatrists and some scholars are saying that actually some serious discussion on death and suicide in fact decreases the idea or ideation, thoughts of suicide. So that's my budding thoughts and emerging thoughts of better suicide prevention. So I will end here. Thank you, everyone. There was a dilemma. One dilemma. I was getting in a rush. But some of the dilemmas. So I did say that the main actors of this field is psychiatrists, and I was thinking, why is it so? Like, why is it so hard for people living with suicidal thoughts or attempts? Why are they not being included in this project or willing to make any changes? I think there is some dilemma related to the the characteristics of suicide. First, suicide, different from other disability or other illnesses, suicide is not considered as disease, illness, or disability. There's no diagnosis. So individuals who are living with suicidal thoughts, they don't identify themselves as people with suicidal thoughts. So that kind of blocks their gathering momentum to make any changes. Another thing is that the fluctuation of suicidal thoughts and attempts is not linear development of suicidal thoughts and attempts. So their conditions vary by time to time. So when they it's really hard to gather the power together with people who are living with suicidal thoughts and attempts. So finally, thank you everyone for
You know, one of the difficult things about the study of mental illness is that it often focuses on the actions of people or lack of action, as opposed to the condition itself. And one of the things about depression is that inherent in the illness itself is an obstacle to care and support. A person may think, well, I'm a terrible person and I don't deserve to be cared for, or they may not have the energy to go and seek support. So I think that's an element that often gets underlooked. I wanted to ask you if there's been, if the government's response strikes you as ever sort of conservative. And by that, I mean that when there are problems in societies, there are always voices, particularly elder voices that have outsized kind of influence, that the cause is because of a breakdown of our traditional values. The cause is of a breakdown of, you know, the family structure and so on, our compressed modernity. And that's why there are more mental illnesses or more difficulties, which seems to deflect the attention, you know, away from systems of care and towards sort of blaming society, right? And yet, I think there's some evidence in your work that many of the people who are feeling or having suicidal thoughts are actually thinking about dignity, not a lack of respect for life, but a respect for their lives, and that suicide could be an agentive form of escape that actually is something linked to dignity. So I'm not sure I've framed my question very well, except to kind of congratulate you for not reducing suicide to any single kind of set of variables, but to answer the question of whether you think that there is that kind of conservative element, because I've seen it with other mental illnesses other than depression.
Yeah. Thank you very much for bringing that points. I do see there are like three main points that you brought up. First one about depression and the suicide. That's related to the dilemma that I mentioned. Many of them had depression. Like, not to say there is no link, but they're having some depressive symptoms when they are thinking suicidal thoughts. As you mentioned, the problem is that they are focusing too much on their own problem, and they are feeling very challenging to go outside even. There was like very lack of energy to do something and to change something. I do hear a lot of like conservative framing of suicide, like family breakdown also, like, and the isolation part is also, I felt pretty limiting, reducing the social aspect of it. And the representative example is like value of life. Value of life is minimized, they say. Yeah, and the social integration that Durkheim says about the like social integration is important in suicide. Like, social integration is important, but that is usually emphasized to highlight the loneliness and isolation and absolving the state to work on the like systematic and structural factors. So definitely there are a lot of like sidelining discourse going on. Yeah. And yeah, if I would like to add, I mean, I want to add dignity part because dignity part, I heard a lot of words using dignity pronoun from my young women interlocutors, and they say, I would like dignity, in my life, and that's why I am thinking of suicide because my life here now, I don't feel as a dignified person. So definitely the dignity was a key word. Yeah, thank you so much.
Questions? Yes.
Hello, great job, by the way. I just want to say thank you so much for doing this. One of my questions is the social impact of suicide, especially on the family, and what sort of like cultural impact, or maybe societal, I guess is the question. I'm trying to really gauge here, what type of culture is established around suicide and what's the response to when young people take their own lives, and how is the family seen as, being held accountable, or, I love what you said about how a lot of these like systemic, these state establishments can evade accountability, looking at these other factors like, personal responsibility to your own life and things like that. So I was wondering how that is also applied on a familial level and how that affects, people around them and in their community.
Yeah, thank you for your question. Yes, the family members, after their family members has passed away, it's really big, there is a big stigma, a huge stigma on that. There are some NGOs working specifically for family members, survived family members, and I have been engaging with the group for a while, but many of them were saying because there was too much stigma. Some of them were even not invited in weddings to the other family members because the others feel that it's not good, or they're thinking that, oh, you should not come because you're not having some good vibe or something. So definitely there is a lot of stigma to family members, and another stigma attached to family members is that they are blaming themselves of the family member's death. So there are some double stigma directing toward themselves and from the external, like other social members. So even though, the state is trying to increase the support of family members in the project as well, it's just starting to begin, like in the early 2010 and early. Thank you.
Thank you so much.
Thank you for your talk, Jung. I wanted to ask a little bit about the politics and the budget for this policy.
Yeah.
Clearly, a priority is Korea ranks top among the OECD countries in terms of suicide rates. But do you discern some kind of partisan differences? And maybe this gets to the conservative values, or in the Conservative Party, in the last few elections, we've seen a kind of feminist turn, or more emphasis on kind of male empowerment. Is that affecting the discussion about how much budget we should spend, what types of programs we should be funding? What does the budget picture look like over time, and are there partisan differences?
Yeah. Thank you for the question. I forgot to mention the budget part. Like, regardless of the political party, the current budget for 2026 is in US dollars $28.5 million. In Korean won is 708억. So that's the budget, and it has been keep expanding. The budget got continuously increased. And regarding the political parties and how they factor in, definitely they are influencing the budget issue and how much they will expand the project. The most important administration expanding was Moon Jae-in Moon administration. In 2018, they were announcing suicide issue as the national emergency. And so when I brought the table, the 5-year plans, it didn't really clearly cut in 5 years because like some administration come in and they were quickening the planning part and trying to expand the suicide prevention project. And I recently saw the news that Lee administration is also trying to expand, and some of the areas are being started, like doing some practical assistant thing. Like she is trying to do some like financial assistance to who have debts and some housing crisis. And it definitely is expanding or being stopped. Well, it remains, but it's not being this expanded based on some of the political parties' voices and opinions. Yeah, thank you.
Yes.
Yeah, thank you for your lecture. My name is Jung.
Could you speak up a little bit?
Yes.
I'm sorry.
Thank you for your great lecture. And my name is Jung. And I have a quick question in terms of national health insurance program. So in earlier your presentation, in the context of suicidal prevention program is introducing the universal coverage of national health program in South Korea. But in the later in your presentation, yeah, you also mentioned about the low rate of treatment of depression, yeah, like that.
Yeah.
So from my perspective, there is a little discrepancy between the context and the real world settings in South Korea.
Yeah.
So I was curious about that why you introduced the national health insurance program as a context of our societal program,
Yeah.
policies and program. And on top of that, I also want to know about your perspective in terms of the roles and responsibilities of national health program. Does it sound?
Yeah, that what was the last one, the National Health Program?
Yeah. Do you have any perspective in terms of the roles and responsibilities of national health, our South Korea's national health program?
Thank you for the questions. First one, I will start with the first one, the discrepancy between the national health insurance and low rates of, I mentioned the national health insurance, 국민건강보험, in terms of when the public health infrastructure got established nationwide to show that that's when national health insurance, public health infrastructure got expanded in South Korea. There are some coverage from insurance related to psychiatric clinics, but some of the other voices are coming up that counseling, 심리 상담, is not being covered by the national health insurance. So even though you can go to clinics from doctors and you can receive some counseling from doctors, but when you go to psychologist counseling center, you will not be covered through insurance. So that's a little bit partial coverage in relation to national health insurance. The second question is really a hard question, and I don't have clear idea on what the role of national health insurance should be in relation to suicide prevention. Maybe thinking of the psychological counseling. I do think that the supporting counseling cost is important. But as I said through my whole talk, I don't think that medical field only or health insurance system only can prevent suicide. I don't know. I don't think, and I I don't think that's the sole responsibility of national health system. They are widening coverage would be helpful, definitely, but that should not be the sole solution or duty from the insurance system as well. Thank you.
We have a question from one of our participants online. Catherine Young asks, thank you for your interesting presentation. I found it truly thought-provoking. In fact, your talk challenged my initial assumption that a state concerned about population decline might pay particular attention to the suicide rates of young women, especially given their perceived reproductive role from a utilitarian or demographic perspective. However, it seems from your analysis that the state does not significantly differentiate between male and female suicides in terms of prevention methods or policy approaches. I found that especially intriguing. I also noticed that in your research, you treat NGOs and other organizations as part of the state apparatus. Have you observed meaningful differences in policies, discourses, or intervention strategies between state institutions and NGOs? Finally, given that the period you examine coincides with increasing ethnic and national diversity within South Korea, have you had a chance to analyze racial or ethnic differences in suicide rates?
Yeah, thank you for these questions. I can start with the very last one. I haven't had a chance to look over the ethnic and national diversity within South Korea. I looked at the government documents and all the white papers they publish every year, the ministry publishes every year. There is no analysis on racial and ethnic diversities in the government documents. Now I'm thinking, oh, like that's problematic as well. There is only like gender, sex, gender, and occupation, age, area, these kinds of categories. Yeah, there's no nationality or ethnic racial diversities there. Regarding the first question, like not targeting or not paying attention to young women in the context of population decrease, I also found that very interesting because I was expecting very different. But what I found was pretty opposite. As I mentioned in the like naturalizing suicide and naturalizing depression for young women, there were some tendencies that treating young women's or teenagers' suicide attempts as death threats. So considering that as less severe. And this relates to the number of the real mortality rate, because I show that real mortality rate shows less number on young women and teenagers because they are using less fatalistic means on attempts. So that's also very interesting, that opposite phenomenon that I have found. Yeah, regarding the state apparatus of NGOs and some other organizations, the important process in regards to alignment of their orientation is that in order for NGOs to get support from state, which is very necessary for them, they have to go through the process of verification. Verification they call 인증, and what they do by verification is that they have to show the design of their own program and has to be evaluated by the state government if their message or their intervention fits with their orientation. So I think in terms of this verification system, their messages and orientation is getting very similar in some sense, although some of the other communities are doing really well, especially for queer communities. They are really doing some effective work by installing their own hotlines, and they already had a strong community there. So in that case, that's working. But when there is a loose community and when NGO comes in and want to do the intervention there, it's not that effective when they already had loose community. So that's the dilemma or thing in state prevention. Thank you.
Questions? Yes.
Thank you for this excellent talk. I have two questions. One of it is pertains to the fact that you seem to be very more inclined to support the more practical kinds of interventions to prevent suicide. And you referred to Japan having a little more success with that. And my understanding is that a lot of that success was reducing the numbers of middle-aged men committing suicide through providing material support for financial distress. And so I'm wondering, and of course, numbers of suicide may signal a breakdown in a welfare system or the social services side rather than individual issues. With the word you used was like the Chongqing choke, the mental disability thing. But I'm wondering if one of the reasons for the gaps in the success was because of the higher charitable involvement of Christians in suicide prevention campaigns, influencing state approaches, including the guidelines, life is sacred, not openly talking about death, and including with the hotlines. And I've never been involved in the suicide prevention hotlines on that side, but being involved on the other side of the hotlines years ago when I was having financial distress, more long-time considerations about financial issues. And while I appreciate what the person said on the other side, some of the things they said, it like came down to a theological discussion, right? About just the remedy of just accepting Jesus Christ as your personal savior, just being able to be that remedy. And I mean, I'm not against Christianity. I consider myself a Christian myself, but it just wasn't the discussion I was expecting to have, even if it was helpful in other ways. So, I mean, that's one side of my question. The other is, on the other hand, Japan, as well as South Korea and the United States, has witnessed, in my understanding, a steady and persistent rise in suicides among young women, which is probably one of the reasons why you focus that to the point where, you correct me if I'm wrong, but incidences of suicide for young women are now higher than young women in South Korea. And so you kind of alluded to some very successful remedies or potentially successful remedies on the economic side, material side. But what kind of practical suggestions you have for state policies towards when it's more on the social side?
Yeah, thank you for questions and experience, sharing your thoughts. Regarding the second question, some practical things, I ask my young women interviewees, like the last question was that, what do you need most, or what would you like to have as your support if you can choose one? And many of them had different ideas, but some common things that came out was housing. And some social safety net, if we say it a little bit vaguely. Some are saying that if I get sick or if I get ill, for now there is no system to support for longer than like 3 months or so. So if they have some practical support like housing or some time to be ill, that will be really helpful for them to continue living in feeling dignified way. So there were some of the answers that I remember. Regarding in relation to Japan, this is just a side note, but I heard that the reason why Japan was very successful in reducing suicide rates was that a lot of people having lived experience of suicidal thoughts and attempts were involved in the project and taking action together. So compared to South Korea, like psychiatrists are mostly leading this project. I heard that Japan, they were more activists or individuals who had actually experienced by themselves. And I think that's related to the Japan's like disability movement, especially I know like mental health movement is really famous and a lot of the schizophrenia community in Japan is very modeled from some of the mental health field in South Korea. They are trying to follow the community in that way. And I think the suicide project in Japan was influenced by the mental disability movement, and including more people with experience. So I think that's another factor that I heard from. I'm not very familiar with the Japan context, but that's what I've heard. Regarding Christianity and faith-based, not sure. But what definitely the hotline, faith-based hotline started from I believe 1960s, like well before the state project started. They were filling the gap of welfare system. Actually, a pastor from Australia came to South Korea and made the most famous hotline, Lifeline. But nowadays they are being supported by the state. They are relying on the public funding from the state. They have to make, as I said, make some alignment with their messages, and I could feel some of the convergences on their orientations, and there are very close connection between the head of the Lifeline. He is taking part in the state project as well. So there are some changing tendencies even in NGOs as well. So yeah.
Thanks so much for the thoughtful
Thank
response.
you.
I appreciate it.
We have an online question that came in, so you might want to look at it. There's some Hangul in it, so you might want to read it if you can see it. Thank you from Y Tom. Thank you for the insightful talk on this important issue. I have a question about public and governmental attitudes toward the word jasal, suicide. On the poster you showed at the beginning of the talk, the word jasal was not used. I also recall hearing the expression 극단적인 선택, extreme choice, used to describe suicide incidents in the past. More recently, however, I've heard criticism suggesting that we should refrain from using 극단적 선택 and instead use more direct terminology. Could you comment on how you're observing the general public's attitude toward these terms, and if you notice a preferred or recommended approach at the state or institutional level?
Yeah, thank you. Yes, as I mentioned in the blog, managing media, like regulation from media, the word suicide, 자살, is prohibited to be used in social media and even for journalists. They have to use, after the act was created, you have to use word 극단적 선택, extreme choice, rather than 자살. So that started from early 2010s. I imagine 2013 or so, after the act was created in 2011. All of the news articles say extreme choice rather than suicide. They, in their understanding, looking at the word suicide, 자살, provokes more suicide. That's why they're blocking the term and not allowing people to use the word 자살, except in this suicide prevention project. Yeah, and I do, that also plays a role significantly in blocking the discussion of suicide. I think that there is a definite relationship between them. And as I suggested in the very last slide, I do think there need to be some very calm and serious discussion on death and suicide rather than blocking the keywords on the media and internet. There is one psychiatrist who are specifically criticizing the term extreme choice because it gives the nuance of choice still, like giving suicide as a choice still. So there are various debates with regards to the term of extreme choice. but the tendency is keep continuing to block the word suicide in every newspaper article and social media.
Thank you. We are out of time. That was fantastic. Thank you so much. Very thought provoking, and it was great. And you really did a great service to the history of this SJP lecture. So thank you.
Thank you very much.